The following was recorded at the CCHF Conference 2023 in Cincinnati.
Okay, great. There we go. I just needed to turn it on. So. Okay, so let me get this back up. But yeah, very, very excited to join you all today here. The frame for this talk really comes from, let me pull this over. There we go. From Acts 1:8. So you will receive power when the Holy Spirit has come upon you, and you will be my witnesses in Jerusalem and in Judea and in Samaria and to the end of the earth. And I think in the space of this story of two stigmas, the opioid crisis and racism in America, Samaria is a good place to start, especially talking about stigmas at that time, with especially how Jews viewed Samaritans. And to talk about stigma, the American Psychiatry Association notes three types of stigmas. So public stigma, which is negative views towards others. But then there's also self-stigma, internalized negative attitudes or beliefs about oneself, often including shame, as well as institutional stigmas, which can be systematic policies or structures limiting opportunities for certain groups. And it's important to note that institutional stigmas can be intentional or unintentional. It doesn't have to be explicit. I think here at CCHF, especially talking about Christian healthcare, we can put on our Ephesians 6 lens, understanding that when we're dealing with stigmas, we're not only dealing with people or structures, but also spiritual principalities and structures going on behind that too. And I think Romans 1:21 really captures that spiritual stigma or the spiritual blindness when it notes, for although they knew God, they did not honor him as God or give thanks to him, but they became futile in their thinking and their foolish hearts were darkened. And even as Christians, after knowing Christ, we still struggle with the renewing of our mind and our heart on a daily basis. And so just because we've come to Christ, we have a new lens on life, but still working through our stigmas and some of this, and the renewing of our minds and hearts. I think beginning with the end in mind, it's important to talk about what is a biblical view of a whole person. And how many of you are familiar with Dallas Willard? Yeah, so I had the chance to take 3 classes with him at USC. He's a Christian philosopher, and in his book, The Renovation of the Heart, he really captures a picture of what a person is from a biblical worldview with a simple visual, that we're not just, and I think especially in the context of our society that's often more materialist, under a materialism or scientism worldview that views us as more physical beings. The biblical lens notes that we're a spirit, right? We have a spirit with a heart and a will, but we're not just a disembodied spirit, but we're embodied. We have a mind with thoughts and emotions, and our mind is embodied within a body, a finite body that we get to navigate the world with, but we don't just navigate the world alone, we navigate it with other people in community. Everyone here with your families, your communities, your clinics, your churches. And those relationships are part of who we are, and the totality of who we are is encapsulated by our soul. I think when we talk about stigma, it's important to even go back to the fall itself, because often stigma mars our ability to see ourselves as who we truly are. And part of the root of losing our own vision of who we are is losing that first relationship with the Father, who sees us as we are. As Adam and Eve fell in the garden and lost that relationship with the Father, so too they lost that relationship with each other as they put on those stigma fig leaves. And so we can think of stigma as this marring of our ability to see ourselves as who we truly are and each other as who we truly are. So this is the part of the talk. If you came early, you got some stigma glasses. So I'll invite you all to pull out your stigma glasses with me. And I'm so glad I don't have to be yelling for the whole presentation, so thank you. But go ahead and put them on. Takes a little bit of adjustment, but we'll try to wear it for the most part of the whole session. And as we put on these glasses, for those of you who have glasses or don't have glasses on, go ahead and turn to your neighbor and tell them what color eyes they have as you see it through your new Stigma glasses. Okay. All right, so you've all looked closely into your neighbor's eyes, gazed into their souls, but had a little filter over that, some Stigma glasses. So we'll try this again at the end without the glasses. But so now that we've kind of warmed up to Stigma, we have these Stigma glasses on. Try to wear them. I know it gives you like a headache, but I'll do it with you. And then maybe our eyes will adjust to our new frames through the talk. So going back to Samaria, I think the story that comes to mind the most with Samaritans is the woman at the well, the Samaritan woman. And really that Jesus' encounter with the woman at the well is a frame for this talk. And at the time, it's important just to kind of set some context that the Jews would have viewed at that time the Samaritans as unclean people. So even to encounter, for him to interact with the Samaritan, he would have been making himself unclean by interacting with a race that was previously Jewish but intermarried and became to the Jews racially or ethnically unclean. Also, as they intermarried, their Abrahamic roots incorporated other religions and elements, so the Jews would have also viewed the Samaritans as unorthodox or religiously unclean. And so the Samaritans were an outcasted people. The Samaritan woman herself, being of Samaria, wasn't just an unclean person to Jesus or to the Jews. She was also seen as an unclean person amongst unclean people, defined really by her behavior or her sin. And so she was an outcasted person amongst outcasted people. And that really sets the stage of how ridiculous it was and unacceptable it was for Jesus to encounter the woman at the well during the noonday, where she had to go get water in the heat of the day because she wasn't allowed to get water when the sun was set with the rest of the Samaritans. And for the Samaritan woman, she was well aware of this herself. Even in her short encounter with Jesus, she highlights these two stigmas, this public stigma and self-stigma, saying, you're not supposed to be here. She says to him, "How is it that you, a Jew, ask for a drink from me, a woman of Samaria? For Jews have no dealings with Samaritans." And then as Jesus asks her for water and talks more with her, he tells her, "Go and call your husband and come here." And the woman answered him, "I have no husband." And Jesus said to her, "You are right in saying, 'I have no husband,' for you have had 5 husbands, and the one you are with, and the one you have now is not your husband. What you have said is true." So the woman really exemplifies these two aspects of stigma, and this encounter with Jesus really frames our discussion today for our modern conversation, both with these two stigmas of race, separating ourselves amongst different people groups, and then even othering people based off of addiction or behaviors that, or sins, right? So, and in that context, even today in America, we deal with this othering and separation between race and ethnicity, or even immigration status or unorthodox religions or beliefs that people may have, and especially as Christians, and even how we still segregate within churches. So we're still dealing with the same dynamics of outcasting or othering other types of people. And then whether it's addiction, and it doesn't just have to be substance use disorders. It can even be, and probably even more important for the church, is behavioral addictions, sexual addiction, pornography, gambling, shopping, etc., social media even. But how we, by people's behaviors, define certain types of people within our society as unclean people and outcast them by those behaviors. And really, this context is important as we enter this conversation. And this conversation that we'll enter here is, we'll kind of do an overview of how these stigmas aren't just from the present in America, but they go to the very roots of our nation. And these stigmas are older than the nation is old. And if you reuse the Declaration of Independence as an example, well, the Declaration of Independence excluded all black people. So directly at the start of the nation, even though people tried to found the nation on godly principles, like Brian Stevenson noted, that the nation imported slavery to start the nation and othered black and other minorities. Dr. Benjamin Rush, one of the signers of the Declaration of Independence, also touches on how we imported our stigma against people struggling with addictions. He was one of the first American psychiatrists at the time, and in one of his books, he advocated for treating people struggling with substance use addictions as a medical disorder, deserving of medical treatment and dignity just as other patients. But he was a minority amongst his colleagues, and his colleagues still saw addiction as a sin that people needed to repent of, something not medical that psychiatrists would treat. And 250 years later, we're starting to have some of these conversations, especially with these stigmas together. And probably one of the reasons why is because the problem's gotten so bad. And so about 2016 was when the mortality rates from motor vehicle accidents started to be surpassed by people passing from opioid overdoses. And the thought goes that if anyone can die from a car accident, and now more people are overdosing, then this is something that now affects everyone. It no longer can be contained under stigma as these unclean people, right? So this is part of the talk too, where I had asked us if you're comfortable, you or a loved one have ever struggled with an addiction of behavioral or substance. Again, if you or a loved one have struggled with that, if you want to raise your hand and keep your hands raised. Yeah, so almost every hand. And then if you know, and for the hands that aren't raised, if you know of anybody within your context, whether at church, work, school, your clinics, who've struggled with an addiction, go ahead and raise your hand. So in some ways, all of us are connected to people who have struggled, whether that's from our own stories too. And if there's any silver lining to that, because it's all hit us personally, it's now created this space for us to start to talk about things that were previously kept hidden. And this is just a graph on some of the epidemiology of the extent of this problem with the overdose rates by Jalal in 2018. The graph on the left shows overdoses increasing by the different substance types amongst the different colors. But what Jalal did, what was interesting, was he combined the cumulative overdoses by all substances and found that overdoses by any type of substance fit on the curve on the right, which maps to an exponential curve that continues to go up today. So it's a disturbing curve because it is not decreasing its slope. But, let's rewind, kind of going back in America, and just to dissect some of this problem. And one of the addiction historians in America, David Herzberg, is actually based out of Buffalo, has started to piece together some of this narrative. And so this is a graph from Herzberg's article. And if there's two key acts, if you're going to learn some legislative history, two important acts to remember are the Food and Drug Act of 1906, which started to regulate safe consumption of food and drugs. And then 8 years later, the Harrison Narcotic Tax Act, which made narcotic sales outside of the doctor's office taxable. So kind of benign acts. What's the big deal? Well, putting Herzberg's, and this is a little complicated slide. What I did was I combined Jalal's 2018 graph with a graph from Herzberg's article to establish a timeline. So on the x-axis, you'll have 1890 through the present. The y-axis, the two graphs note different things. The one here for Herzberg's graph notes annual doses, daily doses per capita sold of morphine, sedatives, and amphetamines, so not overdoses. And then Jalal's graph notes increases in overdoses. But it's the best I can do without recreating the whole graph to establish kind of a reflection across the last 140 years, to really note that this is not the first opioid epidemic the United States has gone through. This is our second. And the first one that the US underwent was after the invention of the hypodermic needle, which then allowed the opportunity to inject morphine. And the hypodermic needle came to America in 1856. And at that time, there was no regulations around morphine. It was, doctors were prescribing it. It was sold on the street. It was an unregulated market. But as you can imagine, unregulated morphine with the hypodermic needle started to create problems. And at that time, there was cocaine as well. And the government needed to manage those problems, both inside the doctor's office and outside the doctor's office. And that started to prompt, as you saw the rise in the blue, that starts to go down after that 1906 Food and Drug Act, which started to regulate safe consumption of food and drugs, mostly by labeling, trying to put parameters around prescriptions and what doctors could prescribe and pharmacies could prescribe, with this idea that with labeling the substances with the risks, that then doctors and patients would do the right thing and not misuse it. And as regulation started to shape within the doctor's office, then there needed to be regulation outside of that, and that was the Harrison's Narcotic Tax Act. That act, while seemingly benign about taxing narcotic sales outside the doctor's office, eventually grew into making sales outside the doctor's office illegal. And once illegal, it set the pathway towards arrest and criminalization, and eventually needed an agency to manage arrests and incarceration. And an agency in 1973 was created around that, which is called at that time the Bureau of Narcotic and Dangerous Drugs, which eventually becomes today's modern drug enforcement agency. And then now in the 21st century, we're dealing with our second opioid epidemic. And now only in 2017 have we, for the first time as a society, noted a public health crisis around the opioid crisis. And these acts kind of get messy because this is the full graph by Herzberg's article. We won't go into detail on all the acts, but the two to remember are going to be that FDA Act and the Narcotic Tax Act at the turn of the 20th century. What Herzberg does in his articles and his books, he doesn't just recount the legislative history, he also talks about the roles the stigmas played behind the legislation and before those 1906 and 1914 acts. And at that time, at the turn of the 20th century, he notes that there were two public narratives of drug users. Again, unregulated morphine, cocaine, opium use. And one was, at that time in the US history, most people coming out with narcotic prescriptions for opioids were mostly white, and particularly he noted white women, but people going to doctors with medical problems or complaints and leaving with a prescription. And at that time, he noted that there was really the health seeker narrative, that they were going to solve their health problems to doctors, and that prompted legislation around that narrative, that 1906 Food and Drug Administration, which really started to try to regulate pharmaceutical practice and then institutionalize these practices into the medical system that we know today. We always look at our FDA-approved drugs and any requirements there. outside of the doctor's office, there was another narrative. And actually, even like recorded on the legislative floor when the Harrison Narcotic Tax Act was passed, people gave testimony of how dangerous these people outside of the doctor's office were using substances. And people outside of the medical system were mostly people of color. Some of those testimonies noted this hysteria of black men using cocaine being a threat to raping white women. And nefarious Chinamen, Chinese opium dens that were a threat to the public, and those cartoons as well in the media. And that really exemplified this minority pleasure seeker narrative. And when America was not shy to talk about its racism at that time. And so that really was the societal and cultural context which created this pathway towards tax regulation, arrest laws, and then eventually a criminal system built off of that connects directly to the work that Brian Stevenson's working on today. And what Herzberg notes is that by institutionalizing these stigmas within laws that don't explicitly talk about race, it institutionalized the segregation between races in our society and perpetuated them. What Herzberg argues is, where do we go from there? One, he notes we have to integrate these narratives, and part of why his work was difficult was in the academic literature, in the historical literature, these narratives are usually told separate. The literature is separate. And so what he's doing as an academic is trying to integrate two lines of literature into one broader, more full story. And he notes the importance of narrative. Again, Brian Stevenson knowing the importance of the narratives we tell ourselves and the willingness to go deep into the discomfort of digging out these stories we tell ourselves and seeing the impacts they have in society and finding new narratives that can break us free. And Herzberg notes the starting place is we just need to first start to integrate and see the problem for what it is and to desegregate these narratives, to start to see the filters that we have on our own eyes. And in the field of addiction medicine, which is now a field that has been established, board accredited ACGME field under the House of Medicine, that was just started in 2017, and it was really founded on the disease model of addiction. So that's the first narrative that has been a powerful force to destigmatizing addiction and to getting people the care they need. Really, 250 years after Benjamin Rush proposed the idea, 250 years later, 2017, the House of Medicine finally acknowledged Benjamin Rush's recommendations. And it really took the advances of neuroimaging, especially functional neuroimaging, understanding the circuits and the receptor level neurobiologic basis of addiction to provide the credibility for the medical field to acknowledge this as a disease. But it's a complicated disease because it's not a disease of any other organ like the liver or the kidney. It's the disease of the brain and the brain regions involved in choice. So it's a disease of choice and agency itself, which is why it's still very difficult to talk about even in churches, because it's a disease of choice and agency. Just a snapshot on the neurobiology of addiction, which we've now kind of created easier ways to really talk about it. One, we can talk about the different brain regions that are affected. So we have the nucleus accumbens in the ventral tegmental area involved in the binge intoxication phase of addiction. With chronic use, substances start to affect the extended amygdala system responsible for dysphoria and withdrawal symptoms. Those withdrawals lead people back to using. And then another part of the brain that's affected is the green areas, parts of the prefrontal cortex involved in diminishing one's ability to value the negative consequences of substance use. It also affects craving and preoccupation, as well as compulsive use. If I were to do any plug for the best 1-hour presentation on the neurobiology of addiction, it would be Dr. Kevin McCauley's Pleasure Unwoven. documentary. He uses the Utah National Parks to create a visual analogy of the different brain regions and talking about the effects of substances on the brain to make a case for the disease of addiction. It's a beautiful documentary because he also talks about his own recovery story through it. And you can find it on Vimeo. That's the only place it's viewable right now on Vimeo. But we've gone a long way because now this disease narrative, the disease model of addiction, is now hitting the popular media with a dramatized Hulu documentary, Dope Sick, that now people are watching for fun, where it talks about the medical, the disease model, as well as medication-assisted treatment with Suboxone in that as well. So we've gone a long way and we've made progress, and that's important. And it's important because this is what I do. I'm a family medicine and addiction medicine physician, and in my addiction medicine side, we know abstinence doesn't work, especially for opioids and especially for the new synthetics like fentanyl, that there's FDA-approved medications like buprenorphine, methadone, naltrexone. I primarily prescribe buprenorphine or Suboxone, but it dramatically decreases the rate of relapse. And every time you reduce a relapse, you reduce a potential overdose, and you reduce a potential death. And so these are life-saving drugs and medications that we're still working to make accessible to patients in our communities. And over the last 20 years, we have made progress. There has been a steep increase in buprenorphine treatment across the nation. Lagisly in 2019 puts it on a graph of increased CMS billing for buprenorphine visits nationally, and notes it increases over the last 20 years, but with a subgroup analysis, they note that the increase is really only among white Americans and not amongst people of color in America. And again, this is why the backdrop of understanding our history with addiction and race is so important with Herzberg's context, because it really helps us understand, as we pushed buprenorphine treatment under a medicalized model, and it primarily is designed to really, Purdue and OxyContin really pushed and marketed and overprescribed opioids to a predominantly white market. And then as we pushed buprenorphine, it primarily also went to a white market as well. And there's actually geographic analyses out of New York noting that you can break it down by zip code. Just as neighborhoods are segregated by race by zip codes, you can find that those buprenorphine clinics are clustered within the zip codes with the white neighborhoods. So it's very structural in nature. And this is found throughout the literature that in the medical system, people of color are noted to receive less addiction treatment, counseling, and harm reduction services. When people of color with opioid use disorders are referred to treatment, they're more likely to be referred to methadone clinics than buprenorphine clinics. That's in part by the zip code geographic separation. There's more methadone clinics in communities of color than there are buprenorphine clinics. And that's a conversation, a whole separate conversation, is how really the treatment has now started to favor buprenorphine because methadone still carries risks such as arrhythmias, overdoses, more sedation effects than buprenorphine. And also most methadone clinics, you have to go every day, whereas buprenorphine, you could typically go once a week to up to once a month. So there's big differences, even the type of treatments that we refer patients to that get segregated by race and ethnicity. And in the absence of the medical system providing that care for communities of color, where do they get picked up? By, again, that criminal justice system, going back to Brian's work and with mass incarceration, where we know that Black Americans, being no more likely to use illicit substances than white Americans, are 6 to 10 times more likely to be incarcerated for drug offenses. And in the 80s and 90s, with mandatory minimums and other drug laws, there was a sharp rise in state and federal prisons, and over half of those arrests were amongst young black men in large cities. And that was pre-COVID data. After COVID, everything has just continued to accelerate. We know that overdoses have increased by illicit substances as well as alcohol use. More Americans are binge drinking than before, and also alcohol-related deaths are increasing after COVID. Something we also saw was that just as COVID affected the legal supply chains for like your furniture or your lumber or your refrigerator, it also impacted the illicit supply chains, where we found that synthetic opioids like fentanyl or even xylazine was getting contaminated into other substances. I remember when I was on the addiction consult service at Stanford, we did an overdose. We treated a patient for a fentanyl overdose who never used an opioid in his life. He had a history of methamphetamine addiction, and the COVID stress prompted him to relapse on methamphetamine laced with fentanyl. And so he overdosed on fentanyl without ever having an opioid addiction previously. And there's been reports too from my addiction colleagues of even cannabis getting laced with fentanyl too. So not uncommon to be doing urine drug screens and counseling my patients that what they're using is actually fentanyl. And after COVID, we saw an inversion of, before COVID, white Americans had the highest overdose rates for opioids. Post-COVID, we now see the highest overdose rates amongst black Americans and American Indian Alaskan Natives, particularly middle-aged men amongst those groups. So we talked about, the current state, and what about the narratives that we tell ourselves today in our society? Helena Hansen and Julie Netherland did an interesting qualitative analysis in 2001 through 2011, reviewing over 100 media articles. These are our New York Times, Atlantic, looking at articles that discussed the opioid overdose issues. And amongst those articles, they noted that they really fell into two categories around two narratives. One, they noted that were more sympathetic portrayals of suburban and rural white Americans seen as victims of prescription overprescribing of opioids. Whereas articles about people of color tended to have narratives of criminalizing urban and black Latino illicit heroin injectors. At that time, fentanyl really wasn't on the streets. It was more heroin at the time. But noting that same health seeker narrative and then pleasure seeker narrative broken down by race. And sometimes it's, at this point in the talk, as we're wearing our Stigma glasses, for those of you who held on with me and didn't get too bad of a headache, maybe your eyes have now adjusted to the filters that you're viewing me and the presentation on. And that's really the racial bias, right? Like the air that we breathe, the water that we swim in, these racially embedded biases that persist in popular culture, that trickle down into institutions, and even the House of Medicine. As a philosophy major, I like to note Ludwig Wittgenstein, the philosopher of language, who notes that the limits of my language means the limits of my world. I think it's so important to note how important it is to acknowledge and to try to understand the narratives that we tell ourselves, because that's our fishbowl. That's the water, that's the limits of our world. It's the limits of our worldview. And unless we start to see and talk and challenge these narratives, this is the air we'll breathe. And so we've talked about how the disease model of addiction has made progress, but has failed to make progress, particularly for people of color in America. And there's actually a sub-cohort of authors, including David Herzberg, Helena Hansen, and others who have been arguing about the shortcomings of the disease model of addiction. While necessary and important and key to my practice every day, it's not sufficient. It's not the complete narrative. And they note that actually this disease model can paint individuals suffering from addiction as worthy of being excluded of social, economic, political participation because of this perception that they have damaged brains from the disease model and therefore need to be sorted by a medical system or criminal justice system. They need to be sorted and managed by the government. And here they note that we need to add this additional piece of talking about harms from substances and aiming to reduce these harms. Some of you may have heard of harm reduction. If you haven't, this is even more controversial in Christian circles. But generally, the idea of harm reduction, so adding to the disease model, is adding the harm reduction model or narrative, really with this idea of meeting people where they're at, going to the underserved communities. Often the communities we serve with our FQHCs and underserved clinics or whichever communities God's called you in your practice, but meeting them where they're at. One example for like our clinics with mobile clinics, having a mobile clinic is a harm reduction approach. You go to patients where they're at. But harm reduction is really an umbrella term that has common principles of meeting people where they're at, starting with their personal goals, and seeing reduction in harms as a legitimate and meaningful outcome in and of itself, apart from abstinence. Sure, I want all my patients struggling with fentanyl, struggling with methamphetamine, alcohol, to stop and never use again, especially when it affects their body in such a way. But I work with them, meet them where they're at. And maybe abstinence is the long-term goal, but harm reduction is the short-term goal. And it includes a variety of interventions. And it's really noted to be designed to meet a diverse group of people. And this is particularly important when we talk about communities of color, a diverse group of people that don't, like one model, one intervention doesn't fit them all. And so harm reduction begins to help us develop a language to providing treatment and inviting others into recovery that our current systems don't serve us well, in fact, perpetuate stigmas with. These are just some harm reduction intervention examples, whether it's low barrier addiction medicine, Narcan, naloxone, overdose prevention, fentanyl test strips in the community so people can know if their methamphetamine actually has fentanyl. Good Samaritan laws, where if you call the police to help revive your friend, you yourself won't get arrested in the process. And then syringe access and disposal, but even supervised injection sites. That is the most controversial thing amongst Christians, supervised injection sites. But these are all harm reduction. And to put harm reduction in context of what we do every day in healthcare, it's important to note that we do harm reduction on a daily basis for every other medical condition. With in terms of the three levels of disease prevention, primary prevention, trying to prevent the new onset of diseases with earlier interventions, secondary prevention, trying to diagnose conditions early and treat early to either cure or minimize the impact of a disease, and then tertiary prevention, taking a chronic disease and treating to decrease the harms of the disease. Well, that's harm reduction, and especially with moderate to severe addiction, this is where harm reduction shines. And we almost have this, we do have this double standard for treating people struggling from the disease of addiction differently than our patients struggling with maybe end-stage COPD that may have resulted from their chronic nicotine use disorder with their chronic smoking. But we don't, look at our patient struggling to breathe, desatting, and say, you kind of been sinning your whole life, and now you're air hunger. That's just God's punishment for you, and I hope you learn your lesson and stop sinning everywhere else in your life. And some of these people get cancer. We don't tell people, you got what you deserved, like, you got what you deserved. We're not going to treat you, we're not going to waste healthcare dollars on you, we're not going to meet you where you're at. But we do that all the time in the area of addiction. And sometimes, people struggling with addiction, the doctor's office and the church are some of the places where they're the most unwelcomed. And in part, it's also because, there's also a training pipeline issue too. We haven't trained churches and we haven't trained health professionals to treat addiction. I went through medical school residency and I think I had maybe 3 hours of addiction training the whole time. That's why I went to do a fellowship. I was talking with some students about, they had 10 hours. So we're making progress, but 10 hours for a disorder that 1 in 6 Americans struggle with, a substance use disorder, we're not treating it as seriously as we treat diabetes, right? And yet we do harm reduction for diabetes all the time. We prescribe and treat with insulin, whether or not they're still eating poorly or not, right? We don't tell them, stop eating your bread and then we'll get you the insulin, and but we do that here. A sub-piece of talking about communities of color that I've kind of dug further into myself is even just talking about Asian American Pacific Islanders with this model minority myth, this model minority perception over Asians, that in the drug treatment addiction medicine world, people often say that Asians don't use drugs, they don't struggle with substances, so no funds go to it, and we just don't talk about it. But in 1971, there was a Japanese overdose epidemic where 31 young JAs overdosed in one summer, which prompted a community to mobilize around that problem that the medical profession did not capture in the coroner's report. And I've gotten to know and partner with this Asian American drug abuse program that was a response to that Japanese American overdose epidemic, to challenge this narrative that this isn't an Asian problem, but the idea of Asians being a model minority is constantly used as a racial wedge to pit white and black and Hispanic Americans against each other, where Asians are often put right between that. So we talked about the disease model of addiction, harm reduction, even the model minority myth, other pieces to the narrative to really see this with a more full perspective. But what about what does a biblical frame and a biblical worldview have to offer? And what I want to do here is, I think this is the time when I talk with my Christian colleagues and friends, and it's like a fresh breath. Okay, now's the Jesus part. Like, now's the answer. But like, what I want to challenge us with is how important all of those other slides were. Like Brian Stevenson noted, we have to do this truth telling for ourselves to get here. But once we get here, we can start to talk about a new story of 2 waters, which is what I love about the Samaritan woman and how Jesus approaches her at the well, because it's a story. Well, let me reframe the Samaritan woman story with this. What if the Samaritans, they knew that the woman would go to the well during the noonday, and she was a sinner and outcast amongst their people. What if they cut off the access to the well? Because only the untouchables would go during the noonday. So we're just going to shut it off, cap it, lock it. Well, it probably would have prevented her from even getting water. She probably would have died after her first or second husband. She would have stopped sinning. So that water at the well, and that water at the well wasn't just any well, it was Jacob's well, right? It was the well in Genesis that God blessed Jacob with and poured water out in abundance up to the Samaritan woman continuing to get water. There was enough water where the Samaritans obviously weren't concerned with her using up their water. And so God was blessing and keeping her alive in a harm reduction approach, keeping her alive up to the point where Jesus can walk up to her and offer her not only the water from the well, but another type of water as well. As he says to her, everyone who drinks this water will thirst again, but whoever drinks of the water that I shall give him will never thirst. The water I shall give him will become in him a spring of water welling up to eternal life. And in many ways, this is what we get to do as followers of Christ in these healthcare spaces, is we get to offer medicine and healthcare and integrating faith and hope into the work. We get to offer water and living water together. What we don't do, or what we're trying to work away from, is saying, here's some water. If you take some living water, Or here's living water, but here's no water because you don't deserve that yet. But we just get to offer both freely, as Jesus did, seeing the person in front of us, in proximity to us, as Jesus came to the Samaritan woman, seeing her through the Father's eyes. As Christian healthcare professionals, and in the space of Christian addiction medicine, I often talk to my colleagues, and in any Christian recovery group, you will always hear them talk about what happens in the life of a person who gets delivered from addiction, is that the Spirit displaces the drug, and sometimes it's a miraculous conversion. Sometimes the cravings stop and they never touch the substance again, but for most people, it's a slow process where they have to do the work, get the support, get the tools, and then they move away from that drug. But whichever path, some of the process that does take place is really captured in Ephesians 5:18, when Paul notes, "And do not get drunk with wine. You can interchange any drug, behavior there, for that is debauchery, but be filled with the Spirit, addressing one another in psalms and hymns and spiritual songs, singing and making melody to the Lord with your heart, giving thanks always and for everything to God and the Father of the name, to God the Father in the name of the Lord Jesus Christ, submitting to one another out of reverence for Christ." And, I think I noted in an earlier slide that this story of two waters is a model and a recipe for revival, because that's what took place after Jesus encountered the woman. She ran back to Samaria, and Jesus hung out with the Samaritans for 2 days. And the woman was a forerunner for her people, these stigmatized people. She was preaching Messiah to the Samaritans, the Messiah being a Jewish person, that he just destroyed those stigma barriers and spent 2 days with the Samaritans. And this is a quote by Kent Dunnington, who's become a friend as well, where he says, "Persons with severe addictions are among these contemporary prophets that we ignore to our own demise, for they show us who we truly are." And so much I think of the Samaritan woman as that. And that's, for me, I've been so blessed every time I work with my patients struggling, wherever they're at in their motivation for change, I get to encounter them as in this space, seeing God working in their lives. And for me, it's seeing Jesus show up in the midst. And sometimes I feel more blessed than I feel like they are from interacting with me. And what I will do with a couple slides is to really note that there's actually real change that takes place in people in recovery. And we actually have neuroimaging and understand more of really you can call it the neurobiology of recovery. People in long-term recovery or abstinence from cocaine use have real brain changes. So this is a study out of Yale with functional neuroconnectivity, connectome, or functional neuroconnectivity studies, noting strengthened circuits between different regions in the brain in the red and weakened circuits in the blue. So these are strengthened circuits in the brain. And you can see it takes place globally throughout the whole brain. This is another diagram to note that these circuits that are strengthened and weakened, and connect all the different areas of the brain. And what they note is that when you look at the strength of these neural networks, the people who are in recovery have stronger network strength than those that are still using cocaine. But they have even stronger connectivity than people who haven't experienced cocaine addiction, or people who haven't experienced addiction. And we see this to be the same in people in recovery from opioid use disorder, these same types of associations with circuit changes within the brain, strengthened and weakened. And actually the literature describes people in recovery as having this hyperfunctionality with these circuits. And they're not just circuits in the brain. This is when people are gathering in recovery and practicing calling one another when they're having stress or when they're having craving. They're lifting weights. They're lifting a 1,000-pound weight so that when that stressor hits, when someone passes away in their family and they want to use to cope with that pain, they pick up that 1,000-pound weight and call that friend. And that's like probably like 10 or 1,000 circuits that have been strengthened and practiced for that moment that keeps them in their recovery. And it took about 100 years for the medical institution to acknowledge that the 12 steps work, and the 12 steps dominate the space of recovery. And we finally have acknowledged it with a Cochrane review, a meta-analysis, systematic review, 27 randomized control trials, noting that these 12 steps work equal or better to cognitive behavioral therapy, motivational enhancement therapy, with reducing drinking and its negative consequences, and it's free too. So I offer both therapy, medication, and mutual support groups, 12 steps within my practice. So this is what we get to offer people struggling with substances or behaviors as Christian healthcare professionals. And I'll comment as I close on this dynamic that we see within the church and healthcare, where sometimes there's this division. My clinic was born out of the Orange County Rescue Mission, which is an abstinence-based, faith-based, 12-step-based program that does not allow addiction medicine. And so, we struggle with this, with the rescue mission, which we were born out of. Now we're a clinic. We offer addiction medicine, harm reduction. The rescue mission does not. And one way I think about it is that these recovery spaces, these abstinence recovery spaces, especially churches, they're really good at working the 12 steps, teaching the 12 steps, integrating faith, and they're really good at working out sin. Really good at getting lives back together, families back together, helping people regulate their emotions, get their jobs back. But they have such a high barrier to entry that if the person doesn't meet that criteria, they're out. And that person then ends up at the addiction clinic, where in the healthcare space, we're healthcare. So we're focused on morbidity and mortality, reducing death. So like mostly a harm reduction lens, prescribing medications, which is really under a harm reduction umbrella. But I would argue that Jesus came to save us from sin and death, not sin or death. And that abstinence, recovery, 12 steps, harm reduction, medications, they're all tools that we get to use to encounter the person in front of us. So we get to use recovery and medications together. We get to, as the church, we've done a lot of talk about righteousness, but we're struggling and starting, and especially with Brian Stevenson, talking about biblical justice, bringing justice back to the church, God's heart for justice, all throughout the Old and New Testament. And in that context, we get, and all of this together, Jesus can handle it. Jesus can handle all of it. And we get to offer water and living water to the person. And we get to see the people in front of us through the Father's eyes. So I promised I'll get these glasses off of you. So Matthew 9, Jesus was criticized for hanging out with people who were stigmatized, unclean people all the time. And this verse talks about his response to that. So while Jesus was having dinner at Matthew's house, many tax collectors and sinners came and ate with him and his disciples. When the Pharisees saw this, they asked his disciples, "Why does your teacher eat with tax collectors and sinners?" On hearing this, Jesus said, "It is not the healthy who need a doctor, but the sick. But go and learn what this means. I desire mercy and not sacrifice, for I have not come to call the righteous, but sinners." And that phrase, "I desire mercy and not sacrifice," goes back to Hosea 6, "For I desire steadfast love and not sacrifice." And Hosea 6 goes back to Hosea 2, 19 through 20, where Hosea models God's heart. He pours out his heart for Gomer, who's living in prostitution, but modeling God's heart for Israel, but also foreshadowing God's heart for the nations to the ends of the earth, including those living under stigma. And his heart is, "I will betroth you to me forever. I will betroth you to me in righteousness and in justice." But he doesn't stop there. "In steadfast love and in mercy, I will betroth you to me in faithfulness, and you shall know the Lord." And I would argue, as we get to see others through the Father's eyes with this heart, that's the thing that starts to melt away the stigma. So at this point, you can take off your stigma glasses, and now you have a heart Jesus glasses souvenir to take with you. And And now we get to begin to see the full person through the Father's eyes. So thank you, everyone, for joining.